Welcome, everyone. So thank you for joining us and welcome to Bowel and Bladder Management Ask the Experts webinar, part 2. Your hosts for this session are Hydrocephalus Canada and the Association de spina-bifida et de Hydrocephalus du Québec. The event is generously sponsored by Heritage Canada. I'm Shauna Bodway, the Director of Programs and Information at Hydrocephalus Canada. I will be moderating tonight's session. For the first question tonight, I will put it out here and you can all answer, but I think I'll ask Dr. Hirschron to answer this one first. How often should I see a urologist if I catheterize and have a bladder augmentation?
Well, there are two parts to it. If someone is on intermittent catheterization without an augmentation, periodic renal or kidney monitoring with blood tests, ultrasound, and also a bladder ultrasound with monitoring of urine as needed. Periodic means once a year, once every 2 years, or something like that. As long as your symptoms are the same, that is, you're stable, there's no incontinence, no change in your symptoms by management, then periodic monitoring is probably important because things do change as you get older. If you have an augmentation, it introduces another potential risk. The major risk of augmentation is that it may change over time. There's an increased incidence of having urinary infection because of mucus production by the augmentation. So you have to manage the augmentation, as you know, with irrigation as required. And sometimes people have to irrigate quite regularly every day in order to wash out the mucus and to prevent stones. But the other thing about augmentation in that you can't just say, well, I had my augmentation at age 5 and that's it. There's a slightly increased possibility of developing tumors in the bladder as a result of having an augmentation, which is higher than the general population. So you have to be monitored. No one knows exactly how often. I have a large number of patients who've had augmentations, and I generally see them every year or two, not necessarily for intervention, but just to keep an eye on things. I do an ultrasound and periodic cystoscopies just to make sure things are okay. So there's no set answer, especially if your symptoms are well controlled. There's no change in symptoms, no increase incontinence, no problem with infection. But certainly if you have symptoms, you should see someone sooner. If things are stable, regular basis, probably once a year, once every 2 years, something like that.
Perfect, thank you. Dilshad, do you have anything to add to that?
No, not at all, actually.
Okay, and Abby?
No, I think that was perfect. That's exactly what I would recommend as well. There's one piece based on just monitoring through the primary care doctor is sometimes you might have some vitamin B12 deficiency when you have certain types of augmentation, depending on which bowel is being used, like the ileum. So I would just recommend talking to the urologist to see if that's something that is required.
Perfect, thank you for that addition. The next question, how often do people with spina bifida develop kidney stones? I've heard they can be painful, but I don't have much sensation below the waist. How would I know if I have these and what should I do to help reduce the risks? Let's start with Dilshad on this one.
Well, with my population, generally, the first sign or my suspicion is recurrent urinary tract infections. And then for the younger ones, they're generally picked up by Abby, actually, and then I'm notified, right? But if I were at Vibrant, it's usually the infections and, the quality of the urine as well.
Okay, thank you. Abby?
Yeah, so I mean, if we're following good surveillance with ultrasounds, hopefully we pick them up. Often we do see some minimal changes in terms of some calcium deposition, and then it's slowly on routine follow-up ultrasounds, you might see some kidney stones. Sometimes these stones are without any symptoms, and so we watch to see how they develop and they grow. And if they grow to a certain size, then the urologist will look into trying to remove them, and especially if they're causing some obstruction to the kidney in terms of the flow of the urine out of the kidney itself. If it creates some stone debris in the bladder, you might have the urinary tract infections as well that Dilshad was speaking about. And definitely with catheterizations, it's a good opportunity to irrigate the bladder to make sure that any kind of stone debris or mucus debris that could create stones is removed. And then, of course, regular routine catheterizations is definitely a must when it comes to that as well. If those bladder stones get to be large enough and cannot be removed just with simple irrigation, then it's a conversation with the urologist to be able to see what kind of surgical options are available to be able to break up those stones, because those stones maybe not causing the same pain that it would for someone who has sensation in that area. Will definitely have a level of discomfort for even patients with spina bifida that have an altered sensation.
Okay, thank you. Dr. Hirschon, anything to add?
Well, that's a good question. There are two kinds of stones that people get. Sometimes they're related, sometimes they're not. Bladder stones can happen in people who have augmentations or people on intermittent catheterization, and they're more common if you have a neurogenic bladder. Bladder stones are not often seen in people who don't have any problem at all with their bladder. So bladder stones are different from kidney stones. Occasionally, a kidney stone can pass down and sit in the bladder and grow and become a bladder stone and give you symptoms such as blood in the urine, increased mucus production if you have an augmentation. But almost always bladder stones are fairly easy to treat, and they can be recognized by some symptoms and also an ultrasound. Kidney stones, on the other hand, are a little bit different. Kidney stones are very common. Even if you don't have a neurogenic bladder, a spina bifida, or spinal cord injury, it can happen in people who are fully functional and have no mobility restrictions. And it has something to do with calcium in the urine and diet and how much fluid that you drink and hydration. It's not uncommon in people to get kidney stones when they don't drink very much and they become dehydrated, and you can form kidney stones. A lot of the time, if they are large enough, they can give symptoms, and you can have symptoms from kidney stones if you feel nothing in your bladder, because the innervation of the kidney or the perception of pain is from higher areas, and you can actually be quite affected by it, even if you have a neurologic problem, such as a neurogenic bladder. So kidney stones are a little bit different. They are, as mentioned, they can be picked up, and they're a little higher incidence if you're not very mobile. And so they can be picked up on ultrasound, and we intervene if they're there, and we advise people to generally drink lots of fluid, stay hydrated, and there are some underlying what we call metabolic reasons why you would form kidney stones. And if kidney stones are a problem, we usually send people to nephrologists to identify what the problem is and have dietary advice and sometimes medication. Now, sometimes kidney stones are related to infection, and that's where there may be a relationship between infection in the bladder and infection in the kidney. And if you get a stone that's a result of an infection in the kidney, then that can potentially be a serious kind of infection, and it can grow into a fairly large stone. So overall, what we do is we practice prevention, and generally people have to stay mobile, drink lots of fluids, on a regular basis to improve hydration and prevent stones, and also improve infection. But basically it's monitoring, and as was mentioned before, if you have any underlying reason to have these stones, monitoring is staying in touch with your healthcare professional and periodic ultrasounds, which will pick it up.
Perfect. Thank you so much. Now we're going to take a question from the audience. This question, I'm going to start with Abby. So the question is, my girl has spina-bifida and a neurogenic bladder and bowel. The question is about constipation and its risks and way of treatments. She has she can't quite control that, but she is quite constipated, but not severely. She defecates everything, then she catheterizes herself. In 2 opportunities, she tried to solve the situation with, I'm not exactly sure what that is, but I'm not sure if you can see that on the question and answer, Abby, but it produces her incontinence for more than 7 days.
Oh, I think that's it's PEG.
Okay, okay. I guess I've never seen it all the way out.
Yeah, I think polyethylene glycol.
Okay.
So yeah, no, this is a very good question. What I try to do is try least invasive options first, and that usually is if she can have other options other than polyethylene glycol, such as some purgative medications like bizacotol tablets, or there is, depending on the age of the child, sometimes tablets may be very difficult. And so we could usually suggest chocolate X-Lax, which many children usually go for. Polyethylene glycol sometimes tips a lot of kids with a neurogenic bowel. Too much and too little polyethylene glycol is results in constipation. And so we marry the two with some magnesium citrate in hopes to be able to get a better option with augmenting the 2 medications like that. So we try some oral medications first. We do try to also then include some rectal suppositories or even rectal glycerin, because sometimes the suppositories don't stay in the rectum because the rectum is open. So we try just glycerin liquid in itself to see if maybe just with a syringe to be able to instill it into the rectum and irritate the rectum a bit. Definitely some toileting strategies. And then we move on to other things like enemas, cone enemas. If you have insurance, we try an option called Parastine that sometimes the insurance company will cover, but it's quite costly. And so you would need to work with your social worker, your nurse practitioner, your providers who have that ability to look into the funding availability, or even contact the only company that creates this is Coloplast. And so you would talk to a Coloplast rep to be able to then look to see if Parastine is an option that would be covered under the funding options that you have. Definitely before doing any rectal treatment, you would have to talk to the provider to see if this is something that is a suitable treatment before proceeding into something like that. And then options like maces and metrophonophs, which we discussed, of course, at the previous discussion. Cicostomy tubes are the antegrade options from above. For those patients that have failed oral treatments and rectal treatments. But definitely there are a lot of oral options to try first, and as well as some toileting strategies that will definitely be helpful to see whether we could try to manage just with medical treatment alone. I'm hoping that I answered the question. I don't know if there's any other suggestions by my other 2 colleagues.
Dilshad?
Sure. So I'm just going to put an adolescent spin on that one. Abby and I work very closely together, and I inform her of what I'm seeing in the adolescent population with all these treatments. The first thing that I usually say and assess is, especially when they're on PEG, is how much are they drinking? Because that population tends to restrict. because they're going to school. They don't want to have to go to the bathroom. They don't want to have social incontinence. They don't want to be using their catheter at school. So they really, really restrict their drinking during the daytime. And they will drink like 500 mils in a 24-hour period. And no amount of PEG is going to help you if you don't have water on board, because PEG does rely on water. So that's usually my biggest issue that I see, is that there's just not enough fluid intake, in addition to some of the things that Abby just reviewed.
So you're saying that you should not restrict your water if you can, because it will help with bowel movement.
Definitely, because for PEG to work, it's an osmotic laxative, so it actually draws water. But if there's no water to draw, or that, sure, there's water and it'll draw it, but if you don't have enough, what I hear is that every time I do this, I get a headache or I'm dizzy. Well, that's because it's siphoned all of your water, right, from your body, and this is what it's doing, and just not as effective. And as soon as they start drinking, like over the weekend, I'll say, well, why don't you do a flush out and just drink a lot? You can do PEG twice a day if you want. And guess what? Like you're just going, right? So you pretty much have to stay close to the bathroom.
Right. Well, thank you
So
for that.
can I add something? It looks like when
Sure.
clarified, the question was not just about the treatment, but also to assess if there's a problem with constipation. So if she is going poop every couple of days without any kind of soiling, and she ends up soiling with polyethylene glycol, I guess the question is, why do we need to treat her constipation? Sometimes what we see is because of the loading of the bowel, it can in turn cause some problems with the bladder, creating maybe a smaller functioning bladder because it's taking up too much space in the abdomen and the bladder doesn't really have much room, and then decides that it needs to empty a lot more frequently by catheterizations, or you might have leaking, you might have some overactivity, which we sometimes see if we don't have a good clean out prior to doing some urodynamics at sometimes. So I find that the reason why we would manage the bowel if there is no problems is more than for the bladder issues, or if we're having urinary tract infections from the actual bacteria being introduced into the bladder because it's being drawn from the gut itself, or from the rectum being full of stool. And often that's the reason for it. So if there's no issues, no soiling, no urinary tract infections, no bladder issues, managing catheters without any problems, and the patient is continent of their stool and managing their bowels to move on a regular basis in whatever form, whether it be through some medication or some digital disimpaction, or doing some Valsalva to empty the bowel. I personally don't have a problem. I just have the caveat that in the future, if there is some problems with the bladder, often it is because of the bowel. If we're struggling with size of the bladder capacity and with continence.
Okay. And Dr. Hirschhorn, do you have anything to add?
No, I have nothing to add.
Okay, thank you. So the next question is about an Indiana pouch, and I believe that this would be for bladder. The person is asking.
An Indiana pouch is a urinary diversion.
Urinary, okay. I thought it was, but I wasn't quite sure. My stoma.
There are many different pouches, but Indiana pouch is called that because it was reported from the University of Indiana first.
Ah, okay. So that's very interesting background on that. So the question is, my stoma where I put the catheter in has been leaking frequently. Is there any way to stop the leakage, or do I have to put up with this for the rest of my life? And this person also lost some weight.
So an Indiana pouch involves creation of what's called a bowel reservoir. So the large intestine is used, it's made into a reservoir, it's separated from the rest of the bowel stream, and the entry into the large intestine is then transferred to the abdominal wall as what's called a continent catheterizing stoma. And the ureters or the kidney tubes are connected to that. Instead of an incontinent urostomy, which people call an ileal conduit, this is an alternative that's very frequently used. Actually, it's not as frequently used as an ileal conduit, but it's a long-lasting, researched and published diversion. However, nothing remains the same as you get older. So if you have a problem with urinary leakage through the stoma of the Indiana pouch, then it's probably worthwhile seeing a urologist to find out what it is. Is it because the Indiana pouch has gotten a little bit smaller? Is it because the catheterizing limb has changed in length? And if you weighed a lot before and you lost weight, it may be a lot more capacious now than it was. That means some of the urine may seep through it and then leaks out. So no, you don't have to live with it. I think what you should see is a urologist who does this kind of urinary diversion to evaluate why you have this kind of leakage. And there are things that can be done to help things along and make it better. But it does involve an evaluation.
And do most urologists do this procedure, or is it a specialized field?
It's a specialized field. Most urologists don't do it. So you'll have to find out either a urologist that you're seeing or ask your family physician or your specialist to send you to someone who has done and does Indiana pouches to evaluate why you have the leakage.
Okay, thank you. Dilshad, do you have anything to add to that?
No, I was actually I had a question for Dr. Hirschhorn, actually. And I just wondered if you actually practice in creating Indiana pouches.
Yes.
In adults, yes, okay. I have a lot of patients at Vibrant, and they're starting to talk about, they graduate from our program in pediatrics, and they start talking about Mace's Matrox and all sorts of things. And other than yourself, I really don't know who to reach out to. So I just wondered, and I haven't had anybody with an Indiana pouch actually.
Well, it's not a diversion that's done very commonly in kids. It's mainly done in older people. In adults, it's more commonly done when you have to remove the bladder for some reason, and most commonly it's for bladder cancer, but it's for other reasons as well, or secondary effects of radiation. It's a choice of urinary diversion that some people select as opposed to having wearing a stoma bag. It's a continent diversion.
Thank you.
But it's been around for over 30 years.
Thank you for that. That's very interesting and really honestly good to know as an option.
Thank you. Abby, did you have anything to add?
No, actually, I don't, but I like exactly what Dr. Hirschhorn had just mentioned. It's not something that we commonly see in the pediatric world. I want to say that in the 12 years that I've been practicing, I've probably only seen one, and it was for a concern of bladder cancer where they had to create the bladder. So, yeah.
Interesting. Okay, thank you very much. So the next question is about bowels and sluggishness. Is that because of my neurogenic bladder or my type 2 diabetes? And what can I do to improve this? Dilshad, we'll go with you first.
Actually, around slow motility and bowels moving slowly, I am going to defer to Abby because she does a lot of teaching and management of that.
Sorry, can we repeat the question again?
Sure. My bowels are sluggish. Sorry, are my bowels sluggish because of my neurogenic bladder and bowel or my type 2 diabetes? And what can I do to improve this?
Yeah, that's a good question. I think it's more related to the neurogenic bowel. I think with diabetes, you would probably have a faster motility. And it's likely more related to the neurogenic bowel itself. And, to be honest, I think that, however way it comes from, a lot of it has to do with diet and fluid intake, as well as scheduling. And without just spina bifida itself, there are many, many people who struggle with sluggish bowels on a whole. So I would say, before we start blaming, sort of the underlying spina bifida, poor spina bifida complex, condition, all of us, there are a lot of people that struggle. We live in a very crazy North American lifestyle that allows for a lot of pushing away of our management for good holistic healthcare. And so I think that if we have more attention paid on making sure that we are getting our fluid intake, getting our proper diet in on time, as well as the variable different types of fruits and vegetables that are needed, and then at that point adding in whatever medications that is required to be able to help the bowels a little bit if it is sluggish related to the neurogenic bowel. I think that in and of itself should be helpful. We don't have, of course, a lot of patients coming in with diabetes in addition to the spina bifida sort of diagnosis coming into our clinics, unless they had a type 1 diabetes on insulin. But there's not a lot of kids that I see with both of that together. So it's not something that I regularly come in contact with. I'm not sure. In the adult population, I'm sure that that's probably a much more common thing to see, as people age over the years. So Dr. Hirschhorn may probably see that.
Okay, Dr. Hirschhorn?
Well, I'm not sure if it's related to the diabetes. It may have more to do with nutrition and diet and lifestyle. When I see patients who have problems like this, I frequently ask a gastroenterologist. So there may be some merit in being referred to a gastroenterologist who can advise you on whether the dietary and bowel management you're using is optimal, or whether you'd benefit from additional medication if your family physician or primary care physician can't help you.
Okay, perfect. So in our first session, we talked a lot about the Mitrofanoff procedure, the MACE, and the C-tube. One of the questions was, are they reversible? Abby, let's start with you this time.
Yes, of course. I think that there are a lot of things that are reversible. We can take down a MACE. We could, sort of close up a cecostomy tube. What I find is, for the patients that have MACE, particularly, if there is any concerns with just regularly putting a catheter in to keep the channel open, I mean, the surgery itself to be able to create the MACE was many, many hours, probably a number of days in hospital to be able to recover from that, as well as maybe some really good years, hopefully, we hope, of catheterizing and being continent and such. But I do know that there are either some patients who don't do well despite a MACE being created, and find that it's just not working, that may be looking to take it down, or if we have potentially maybe a perforation of the appendix channel itself that needs to be emergently taken down, or if suddenly the bowels are working, which I can't see in a neurogenic bowel population, but maybe in someone that has the ability to sense the ability to or the urge to defecate, and be able to use toileting strategies and such, and may not be needing to use the MACE on a regular basis. I still do suggest to consider, if it's not causing any problems, to just leave it alone and catheterize the MACE stoma once in a while to keep the channel open, so that at any point in time, if things suddenly change, you have the access to be able to irrigate. But of course, if there are problems with it, then definitely they all can be taken down.
Okay, thank you. Dr. Hirschhorn, anything to add?
Yeah, they can be taken down, and sometimes they are quite problematic, and they have to be taken down. They can be fairly simple, just removing a cecostomy tube if it doesn't cause trouble. But sometimes you actually have to go in and operate and fix the hole in the bowel, because it is a hole in the large bowel, and you don't want to get into trouble with that. So each case is unique.
Okay, and Dilshad?
The only thing that I can really add, to be honest, from an adolescent standpoint, and we touched on it the last webinar, is when they do want to take it down, it's generally because of the fact that they're having to sit on the toilet for long periods of time, and they're running out of time. They're studying for exam. In fact, I had one patient today who was complaining of exactly that. And so then they request an exploration around taking it down.
Okay, thank you. And this is still a question with regards to Mitrofanov. At what age would you recommend this procedure? And the person who asked this question, their child is 3.5 years old.
I could definitely answer that since I'm from a pediatric part. So I think that doing a Mitrofanov earlier to be able to allow for ease in catheterizations, as well as to be able to have some teaching started, is always great. I think that we're always trying to encourage families to start with urethral catheterizations in the beginning and see if they're able to teach them how to do urethral catheters, which is tough for a 3-year-old to be determined, right? You know, they're very young. However, that being said, in our spina bifida clinic at Bloorview, and now this is an anomaly, we don't have many of them, but I have an 18-month-old who is doing everything but inserting the catheter in. And that is quite weird. But what I'm saying is that the challenge is there to be able to start the process early. And so what we try to do is, from the get-go, from newborn stage, start the catheterizations to be initiated and practiced. And even if they don't need catheterizations, we are trying to encourage families to continue with at least once a day catheterization, so that when we're getting ready to go to school, we're not stressed with the idea of relearning catheterizations for the parents. The children also have been conditioned to be used to the treatment itself. And so increasing the number of catheters are not a stressful thing. We often definitely do urodynamics prior to school to understand what the catheter needs or the toileting needs are, so that they can also follow the same trajectory as their peers who are coming out of their diapers. And so with the urodynamic support, we can then consider the use of more catheters or medication to be able to provide that continence. So I can't really say Mitrofanov is something that we're considering for the average spina bifida patient at the age of 3. Definitely there are some children who are looking to need maybe a MACE at the age of 4 and 5. And if you ask all of the surgeons, their preference for an appendix is to use for the Mitrofanov because of the way that the channel can be created and its benefits and less leaking and such. And so what I try to do is I try to encourage as much as possible some avid teaching over the couple of years before they start school. But if we realize their mobility or their fine motor skills and the way that they're positioned is really going to make it difficult for them to do their catheters on their own through the urethra, then at that time, we're considering to do a Mitrofanov for that reason. And then that's where I would say a 3-year-old probably would be looking to do a Mitrofanov. So my first inclination would be to suggest to do some teaching on urethral catheters, and to know that females don't do catheterizations by visualization. They're doing it by touch and feel, and initially maybe using some mirrors, trying to learn how to do catheters in the bathtub, in terms of being able to have that space and luxury not to have urine spraying everywhere. The nurses at Bloorview are experts in helping families through that whole teaching process. And if they are struggling at home, to bring them in to do maybe a teaching sessions at the actual hospital itself. And so there's lots of opportunities to be able to do this, but definitely for kids who have been conditioned to the treatment early on, I find that their parents have a much easier way of transitioning them to do catheters if they start to do the process early on.
Thank you, Abby. Dilshad, do you have anything to add to that?
No, I don't actually.
Okay, thank you. And Dr. Hirschhorn?
Well, it's just that Mitrofanov is just another way of catheterizing to make it easy for people to do it. I don't see kids, so I see kids after they leave sick kids. So they're 17 or 18 years old. And it's something that in the population I see, it's the patient himself or herself who makes that decision. And it just gives some more independence rather than relying on someone else to do the catheterization. It actually makes it easier to catheterize because you don't have to get out of your wheelchair and lie on the bed. And so it gives that extra degree of independence. So once the decision is made, then of course there's the risk of the procedure and the long-term and the short-term complications. So it's something that you have to think about very carefully. It's got to be done at the right time, not too early perhaps, because then it's a longer term possibility if the tissues are smaller, a little bit more fragile. I think the kid probably has to grow up a bit before you undertake a Mitrofanov, unless there are other reasons that make catheterization through the urethra impossible to do. But it's something it's not a decision that you make lightly. It takes time, and it's over time that it's made.
And on the flip side of that, Dr. Hirschhorn, is there an age where you wouldn't do a Mitrofanov procedure?
No, I think there's no age limit, provided the patient is highly motivated and there are good reasons to actually do Mitrofanov. In the adult population, sometimes the urethra becomes unmanageable, it's unrehabilitatable, and it's really all you have is suprapubic access, whether it's going to be a permanent suprapubic tube, or if you can do something with the urethra to make it not leak, then you provide that abdominal stoma.
Thank you. One question that we have from the audience is, at what age do kids usually learn to catheterize themselves? And from my experience, working with the association, it varies very much. So I'm just wondering, Abby, if there's an age range where you usually start to teach kids about catheterization.
Yeah, no, I think it definitely depends on how the catheters were introduced and when it was introduced. So as I mentioned, if these catheters were introduced in the newborn stage and have been followed regularly in clinic for routine surveillance with ultrasounds, often we are talking about starting to initiate some conversation about catheter teaching way before they're entering into school. And so it doesn't mean that today the parents are doing it and tomorrow they're completely taking it over. It means that often when parents are doing the catheters, they're doing a lot of the steps in their mind, and the kids are not understanding what those steps are. So what I usually recommend is maybe verbalizing those steps so that it's sort of like a mantra over and over. So if they're being catheterized 4 or 5 times a day, that same sort of verbiage just happens regularly, and the kids end up taking it on. Sometimes what parents can do is create little templates with pictures to kind of outline the steps in picture form, and that really helps. I do recommend having the children participate in the steps in some way, meaning they wash their hands, they're helping opening up the package, they're, holding maybe the lubrication. If it's like a non-lubricated catheter, it needs to be lubricated, to be able to hold the catheter and remove the catheter. Those things shouldn't have any concern in injury or mismanagement in any kind of way. And then the last step is to be able to introduce the catheter into the urethra, and often it's hand over hand. And then, like I mentioned, using different tools. For females would be mirrors and such. For males, it would be a little bit easier potentially. And so it all varies. Now, we do have a lot of children who may have been on once a day catheters, having very small volume from it, and quite incontinent into their diapers, and doesn't matter how often we increase up the catheters, we don't tend to have any benefit from it, or maybe there might be other reasons why we couldn't adjunct the catheters. And so for that reason, it might be difficult. And we might need urodynamic support and surgical support to be able to allow for that continence to be able to progress. But definitely as early as possible, just kind of consider the same steps that people would take to put dishes away, to make their bed, the same sort of thing. This is something that hopefully once they get into school, less hands-on from EAs and teachers as much as possible, to maintain their privacy. For sure, any child that goes to the bathroom at school, you cannot guarantee that they're washing their hands. You cannot guarantee that they're doing the proper steps. And so we do probably need a level of EA support for a number of years to make sure they are washing their hands, not throwing the catheter onto the floor, into the toilet, picking it back up again, putting it into their urethra or the metrophenol, whatever the case is. And so there is some support from EAs for hygiene. But the point that I usually make to parents is the summer or the previous school year before the child starts school. So if they're starting in September, that would mean the end of the previous school year. So in June, the parents should be reaching out to the school to be able to let them know that their child will need catheters, or are looking to need catheters, so that they could then look to budget for educational assistance for the coming year. Otherwise, what will happen is that as we enter into the new school year and we're starting catheters maybe in January, now we're kind of stealing EAs from other programs to be able to try to support the catheterizations. And it's quite difficult, with all of the coverage concerns, plus also if we need to do catheters for medical reasons too.
Okay, great. So the next question is about Botox injections. So Dr. Hirschram, maybe you can answer this one first. I had a Botox injection to help with bladder pressure and continence, and it failed. The medication I currently take will shortly be discontinued. I am a full-time student, and I currently can't go more than 3 hours without self-cathing. What would you suggest?
Well, it sounds like you're quite intent on managing your bladder, and that's very good. There are things that can be done. Having had one Botox injection doesn't mean to say that it's not going to work the second time. And that was shown in a number of clinical trials. So the first thing is, it's probably worthwhile trying either the same dose, or you can actually have the dose increased in order to see if you'll respond to the Botox. So it's worth a try, one, maybe even 2 times. The other thing is, to go back to square one, you have to be sure that the incontinence itself is not only result of an increase in bladder pressure or what we call detrusor of activity. There may be other components of the incontinence that just may not respond to something like Botox and may require other kinds of manipulations or maneuvers in order to address. So a reevaluation by the urologist may be necessary. If it shows the same thing, then Botox can be tried again. Regarding medication, I know that it's a long-acting oxybutynin. The long-acting form has been discontinued, but there are a lot of different alternatives available now. There are other medications called long-acting antimuscarinics that are similar to the long-acting oxybutynin, but there are other preparations. There's also other types of medications, they're called beta-3 agonists, that are now available, and even combinations. So oral medications alternatives are definitely available. Another injection of Botox, perhaps at an increased dose, is also a possibility. And also reevaluation to see if that's the right treatment you're embarked on, or there may be other treatment strategies that may be possible. So it's certainly worthwhile going back for more treatment.
Thank you. Dilshad, do you have anything to add to that?
No.
Abby?
The only thing that I would probably add is just a reminder to everyone to understand that we are not robots, right? You know, even though we have a catheter schedule of every 2 hours or 3 hours or 4 hours, we shouldn't worry about sticking to the schedule because depending on maybe how much fluid that you may have taken in, it may overexceed your bladder capacity, and anybody, if they drink lots of fluid in a short period of time, will need to go to the bathroom a little bit more urgently or a little bit more frequently. And so that's with anybody. And so I think that the main reason why we stick to schedules for catheters is because of the fact that there are a lot of steps that go with it. It's not as simple just to go to the bathroom and just go and have a pee. You have to do a lot of steps more than the average person that's toileting. And so that's why we try to, create some schedules, create some balance. But if you are drinking a lot more fluid, you might have to catheterize a little bit more often based on that volume. And so I would just sort of recommend to also think about that. Plus also, the sensations may not be there and you may be waiting for, last minute sensations as well. So consider that, as well as the fact that maybe make sure that we're emptying the bladder efficiently so that we are not having an inefficient empty of the bladder. Often when we do urodynamics testing and they come into the suite and we have patients or parents catheterize, they're not actually catheterizing deep enough and in fact, inefficiently emptying the bladder. And sometimes we can only see this just because the fact that we have the contrast there. I have them catheterize and then we do a final scout and lo and behold, we're not emptying efficiently. And sometimes it's not because of technique. Sometimes it's just the choice of catheter size. So you may need to increase the size of the catheter for more efficient emptying. And often you could see that in cases where they may be having recurrent urinary tract infections or the flow of the catheter is very slow.
Okay. So we're almost at 8 o'clock, but there was quite a few questions about the use of laxatives such as Senna or lactulose, Prodium, Colace, and Restoralax. I guess the question would be, can you overuse these products when you're trying to empty your your bowel? And is it okay to take them on a daily basis? How often should they work? Or how quickly should you think that they would work? So we'll just try and get through this question real quick and then we'll wrap up. Dilshad, you're nodding your head.
That's a really quick question, but the thing is that everyone's really different, right? And what one person might need is different from another, right? So one person might need just the one medication versus laxative versus another person, depending on your motility, depending on how much stool loading you have, depending on your diet, depending on whether you have diabetes or not, right? And because with diabetes, I wonder about, you know, if it's really bad diabetes and if there are changes in the nerves, you know, that's an added effect on the poor neurogenic bladder or the stomach for that matter. So I think it's very, very individualized. So I can't say that every single day is too much or 3-4 is too much. And for social continence, it ends up being what you need, right? But everything should be explored in that, you know, the root cause. As long as we are clear on that, then I think the treatment can be very much individualized, and there's no right or wrong.
No right or wrong. Wonderful. Abby, do you have anything to add real quick?
No, I think what Dilshad mentioned was actually perfect. And just the idea that a lot of trial and error requires a little bit of time. Sometimes if you do 2 days of something and you're anxious to then add another medication, sometimes you haven't given that previous medication a chance to take hold. And so often I usually suggest, like, let it happen for a couple of weeks before you're starting to increase dosing or add medication, because often then that's what ends up happening in increasing the number of medications you're using. You're just not giving the time it needs to be able to make it work.
And Dr. Hirschhorn, would you concur with that, even
I
with
concur.
bladder?
The bladder is different. I have nothing more to add to this question.
Okay. Well, thank you, all three of you, very much for your time tonight. Great information shared with our population. And we just thank you so much for supporting our community the way that you do. So have a good night, everyone. Take care.